Wonderful. Thank you for that introduction. Let me just get acquainted here. Can you hear me okay? All right. So, first of all, thank you for having me. It's a lovely turnout, and thank you all for joining us with the Congress today. I wanted to tell you a little bit before I get started about the work that we do here in Waterloo at the University of Waterloo. So, I run the Neurocognition and Mobility Lab. We're located at the University of Waterloo. I actually got trained here at Laurier in town here and then over at Waterloo. So I might have seen you all, some of you maybe, if you've had the disease long enough, as a student, because I worked at the Movement Disorders Research and Rehab Center when it was there at Laurier, doing a lot of physical rehab at the time. And I got bitten by the bug where I worked with this lovely lady for about 10 years doing rehab. And she inspired so many questions, research questions mostly, around her mobility, around her walking, around her mood and how that interacted. And so from there, I just never left the world of Parkinson's. I started with my undergrad and did my master's and PhD, went to Australia for a bit to do some brain imaging, and then came back and they hired me back here to continue work with research in Parkinson's. So this is my team, lots of really clever and bright young minds. If you end up coming to the University of Waterloo to do any research studies, we're located just off of Columbia Street on the second floor of the health building. We also do a lot of research out of the care building that's up in the Tech Town Park. And then you might be wondering, well, what kinds of research, what does research look like when you're talking about research with mobility? Oftentimes when I tell my parents what I do, they think that I'm dressed in a lab coat and I've got test tubes and so on. That's not at all what we do in the lab. So as you can see here, we work a lot with virtual reality or just with the spaces that you would encounter within your home or in your regular environment. Virtual reality allows us to bring the outside, what things that you encounter on a daily basis, like a grocery store or crossing the street, these casual things, but they cause quite a bit of challenges for mobility, and we want to understand why that is. And so we bring them into the lab and we study them with a number of different ways. Sometimes we look at how your eyes move around to see how you might be paying attention to those features of your environment, if you're extracting information that you need to and ought to be using to plan your movement correctly. Sometimes we look at your heart rate or your blood pressure, or maybe how much you're sweating to see if you're stressed out. And I'll talk a little bit more about how these measures provide us insight as to risks that you might have for falling in the future. And then sometimes we can get fancy and put a helmet on your head and look at oxygenation brain activity that you're recruiting to be able to control your mobility and watch your footsteps on a pressure sensor carpet to really get a sense of how are you, how stable are you on your feet? How much does your balance and your walking steps vary? A healthy amount, an unhealthy amount? Can you adapt really quickly if we give you a perturbation and so on? So those are some of the things that we have going on in our lab, just as a side note. And I'll kind of feature a little bit of what research we're currently doing in case that interests anybody. So the topics that I'm going to cover today, first we're going to do what is mobility? Why is it so important? It's constantly ranked amongst the most important symptoms that matter to people living with Parkinson's disease, and rightly so. We're going to talk about how Parkinson's affects mobility. We're going to really feature measurement because I think you'll probably be seeing across a number of different outlets that we're getting more sensors that we can measure, various behaviors in different ways. But we have to be really critical about whether those measures are meaningful, are they accurate, and are they reliable? And they all have their place. So we're going to talk briefly about that, particularly related to mobility. We'll talk about falling because that's one of the major outcomes that happens later in more advanced stages, but when our mobility is challenged by Parkinson's specifically, but also just with regular aging. We're going to share where and why this happens and hopefully give you a few tips to, similar to your sleep hygiene, maybe take a look at your home and ensure that there are no tripping hazards or slipping hazards. I've counted a few in the hotel already. So we'll talk a little bit about stress. Stress plays a major part. Fear of falling and just your emotional reaction to different environments or your disease can actually really compete with the attention that you need to dedicate to your walking, because the Parkinson's influences how automatic you can walk and navigate around. So managing your stress, similar to helping your sleep, can have a major impact on mobility. And then we'll get into freezing of gait at the very end, which is a very disabling symptom. If I get talking too fast, somebody just give me a little bit of a stoplight. It just means I'm getting excited. So mobility, what is it and why is it important? So mobility is one of the most fundamental ways in which we can get around and do the things that we like to do. It's core to your independence, being able to do things by yourself. It's core to your sense of self. It's core to your quality of life. When mobility starts to decline, we often see that people tell us and feel as though their quality of life is also very much declining. And for that reason, you want to make sure that it's front of mind, that you're prioritizing sort of good practices in maintaining your mobility, because if you neglect it, it can have quite a cost later on. And so when we talk about mobility, sometimes you might be thinking, well, I'm not sure, but what I'm talking about mobility is the most typical one is just walking, straight ahead walking, right? You think about you'd like to go grab a glass of water, you walk to the back and you go get your glass of water. We can measure walking by taking a look at your steps. How large are those steps? How wide are they? If you're walking really, really with a wide base of support, you're probably a bit unstable. You're trying to be cautious. There's also gait initiation. Gait is a fancy term for walking. So when you initiate walking, you're basically unloading one leg in order to be able to lift that leg up, right? If our center of mass is over top of that leg and we lift it up, we're going to fall over, right? Because we haven't shifted it to be well within our base of support in order to lift it. As we'll see, Parkinson starts to affect all of these facets, actually, of mobility. Turning is a really important part of mobility. We often don't think about it, and for a long time it wasn't studied very well. A recent study showed us that we actually turn more than 1,000 times in a day. So turning is very, very important, but it also puts us quite a bit off balance, because as you can imagine, you're turning and you're often on one leg, changing direction. That's quite difficult to coordinate amongst your segments as well as with your muscles. And Parkinson's changes the way that you turn. So we'll talk a little bit more. And then finally, gait adaptability. So this is sort of the most complicated. Gait adaptability is, when you're walking along and you're doing your straight line walking, and all of a sudden, a child runs out or your pet runs in front of you, and you have to quickly adapt your walking behavior, step to the side maybe, or maybe pump the brakes and quickly stop. But you have to be able to adapt, and oftentimes we see this most commonly when you're outside of your home, in a grocery store, in the shopping mall, and this sometimes can be a source of stress. Because these adaptable situations are often not predictable. And for someone with Parkinson's, it can take a little bit more time to ready that plan, adopt that plan. And so triggers of gait adaptability can often lead to flaws. Okay, so I also just wanted to briefly highlight there was a research, so what is it and why is it important? I touched on this, but there's a really nice research study that was done where they interviewed a number of people living with Parkinson's to actually get a better understanding of how important the walking experience is. And they found, as they themed the responses within the interview, that walking has an experience that branches on both the mental and emotional experience, your social experience, and your physical experience. So there's a number of things that are crucial to sort of being you and your identity that wraps your walking experience up. And as you change, or as the Parkinson's changes your ability to walk, it actually has a pathway or an opportunity to change your sense of self. Okay, and I just wanted to point that out because I thought that was actually quite a unique finding, that your ability to walk and actually yourself represented while you're walking adapts with the disease and with the disorder, and we should be aware of that. It also, of course, impacts what kinds of activities you can take part in, and so on, which is all a good reason to make sure that we're doing all that we can to preserve it. So how does Parkinson's affect our mobility? Let's talk about a few different, break it down into sort of the building blocks of mobility. If we start with balance. So as you all may know, or some of you may even experience, oftentimes with Parkinson's, your balance becomes more unsteady. Okay, a simple way to test this within your own home is to just close your eyes and see if you start swaying a lot more, right? Oftentimes, your neurologist might get you to do the flamingo test where you stand on one leg. That ends up being very, very challenging. As Parkinson's progresses, you might not need to even close your eyes. You might already feel spells of dizziness or unsteadiness on your feet. We're going to talk about why this is on the next slide. But in terms of walking, again, these are things you probably have already noticed, but a common really early feature, actually as early as that REM sleep behavior disorder symptom, which can happen almost 10, 15 years prior to your diagnosis, you can start to see asymmetry within your arm swing. So typically your arms are there to actually keep you really well balanced and the energy conserve while you're walking. Parkinson's disease starts out asymmetrically in the brain, and as a function of that, we lose our arm swing on one side. You can also see that your steps become more asymmetric. Eventually, as the disease progresses, this becomes more symmetric again, and you'll probably see that both of the arm swing is either reduced or almost completely gone. This is, again, it has implications on your ability to dynamically influence your balance or catch your balance, because oftentimes we use our arms to propel our center of mass. If we're about to fall, we might put our arms out. And so these are some of the reasons why we're not able to catch our balance as quickly and are at increased risk of falls. I talked about, walking. There's a number of other features within walking that become impaired. You might be aware, or certainly are aware, that your steps can become a lot slower. Your steps can become a lot shorter. Oftentimes you're walking, when I showed you that map of your steps, when we look at it on a carpet, they also become much, much more variable. What that means is that typically when we're walking really automatically, we've just got a program that we're executing, and that step is the same step again and again, and as long as the environment doesn't change. But in Parkinson's, that's shifting, and that's giving us a bit of insight that actually what used to be automatically controlled in our brain is no longer automatically controlled. We have to start paying attention. And I don't know if many people play golf in here, but if you're a golf player and you start paying attention to your swing gets worse, doesn't get better. Your body probably knows how to do it a lot better if you don't pay attention and just let the kinematics handle themselves, because your brain has learned a really efficient pattern to hit the ball. That's the same with walking. But unfortunately, that part of the brain, the basal ganglia that's impacted with Parkinson's disease, especially at the back, that's responsible for executing those automatic movements, starts to decline, decay, and become damaged. And so the other part of the basal ganglia, the more front part, takes over and calls our attentional networks online. And it's just not as good, unfortunately. In terms of gait initiation, we spoke briefly about how important it is. They're called anticipatory postural adjustments. It's just a fancy word. When our center of mass is seated here, right? If we were to lift it, and your center of mass always has to be inside of our base of support. So my base of support is where my feet are touching the floor. If I hang on to the wall, now I've extended my base of support to the wall and all the way around my feet. So this is really important because oftentimes we need to move our center of mass to keep it safe within our base of support. If it's not, then we'll start to tip over and fall. Unfortunately, in Parkinson's disease, the force that it takes to move that starts to decline. And so it can take a few times to get your center of mass over your foot to be able to lift off. And this is seen other places as well. Turning behavior characteristically changes. We call it on-block turning. So in healthy aging, you typically turn with your eyes first, and then your chin follows, and your shoulders, and your trunk sort of rotates. And that's a really natural segment coordination, and that helps to ready the foot. Oftentimes in Parkinson's, we get stiff. And so with that stiffness, we kind of move all at once, and we take really small shuffling steps to move to the side. And unfortunately, those small shuffling steps also put us at greater risk of of losing our balance. And then gait adaptability, as I mentioned, there's a number of reasons why the adaptability starts to be impacted, and I'll touch on that in this next slide. So I spoke about kind of what Parkinson's gait looks like, the features, the reasons for, or some of the mechanisms as to why this happens. That's not as well known. So first of all, Parkinson's is not just motor, as you have talked about throughout the whole day today. There's sensory changes that happen. So your vision changes, your vestibular system that controls your balance, when you're in the car and you sense that you're moving. That also changes, as well as the sensors within your muscles and on the bottoms of your feet. And all of these, as they start to decline, these are really, really important information that allows us to know that we're upright. And it's a very tightly tuned system that constantly is tracking where your center of mass is and then reacts when it needs to. If it gets too close to the edge of your limits of stability, your edge of your toes, for example, then you might get a step. If it gets too much to the side, you might put out your arm to grab onto the couch surf, grab onto a piece of furniture. The challenge is if that equipment, the senses, don't do their job to really understand where that center of mass is, and it's a bit delayed in flagging to the brain, oh, we're getting near the edge, we better take a step or recalibrate. What ends up happening is that you end up having to generate a bigger force, a faster force to recapture your balance. And unfortunately, as we know with Parkinson's, we can't move as quickly and with as much force. And so for that reason, you become more at risk for falls. Likewise, in terms of our muscles, it's not just our senses. Our muscle strength often declines, which means that when we do start to fall and we need to create a really big force with our quads to catch ourselves, we don't generate enough muscle force. And so that might look like a number of steps. You don't just get that one, but you generate a number of steps to try to catch your balance. And then unfortunately, our range of motion also starts to reduce with the rigidity. I spoke a little bit about this, but this diagram just sort of shows, so in the middle here, and I can't really see the big screens, so I can't really point with a laser efficiently, but the center of the brain that you see there, that's the basal ganglia. That's what I was talking about with respect to your automatic motor programs. It gets to be really good, even in children, at freeing up the rest of the brain to be able to think, so that we don't have to think or walk. We can do both by processing things in parallel. That's one of the lovely features of our brain. Unfortunately, all those parallel loops, or a lot of those parallel loops that process, go through the basal ganglia. So as the basal ganglia gets degenerated, now all of a sudden you get crosstalk, all this interference, because those what used to be parallel loops that could work simultaneously are basically flooding the information in the same places, and now you've got interference. It's kind of like, do you remember when we used to have dial-up internet? Right? You'd have dial-up internet, somebody would get on the internet, which worked great. You could get on the internet, you could do your thing, but if someone picked up the phone, then your internet crashed. And that's kind of what's happening here. You might be able to carry out your walking behavior on your dial-up internet, but if your wife calls you and she starts talking to you, she just picked up the phone and interfered on that signal. And now all of a sudden you've got some crosstalk interference, and it might either result in you have to stop walking because you can't do two things at once, or maybe your balance becomes perturbed, or in very, very severe cases, this is often where we see freezing of gait. Okay, so this slide is probably a bit too busy for what it needs to tell you, but I just wanted to highlight for everyone here, I'm sure you've heard the phrase, if you've met one person with Parkinson's, you've met one person with Parkinson's. And I think that that's really just important to touch on here as well, because what you can see on this diagram is all of the different ways that Parkinson's can progress. And the reason that that's important is I just want to make sure that I couch what we talk about today so that no one's feeling as though they're walking away with doomsday right ahead, with mobility challenges and stuff, because that doesn't mean everyone is going to go in that direction. So this is a little bit of a complicated chart, but what you can see here is each of those bar graphs represent a dimension, a factor that influences how Parkinson's progresses. So you can see if you're REM sleep behavior disorder negative, if you've never had that, you're already in the green. Your trajectory to continue on with Parkinson's at a slower rate and so on is a lot better than if you had REM sleep behavior disorder. Okay, REM sleep behavior disorder early on puts you at risk for the mobility impaired subtype of Parkinson's. There's a number of genetic risk factors that you may or may not be aware of within yourself. But importantly, your age of onset also has an impact on how quickly the disease progresses and how quickly mobility gets impaired. So if you're young at onset, it's going to be a bit slower than if you were older at onset. Your phenotype is a really, really important. So if you have predominantly tremor, oftentimes people who have predominantly tremor may not have mobility issues as quickly. It actually may be quite a long period of time until they start experiencing challenges with their mobility compared to individuals who present with some of their first features as shuffling gait, for example. Your non-motor burden, so your sleep impairments, your cognitive impairments, your mood impairments, the more burden of non-motor symptoms you have, those go hand in hand with mobility issues. So that's an indicator for advancing stage mobility decline. Whereas if you don't find that those features are present in your form of the disease, it might be a longer time until you experience challenges with mobility. And then the same with cognitive burden. But I will say that at the end of the day, mobility is something to be aware of when you're aging. Healthy aging, good mobility is instrumental. So I wouldn't neglect it just because you don't have those features right now. A quick note on if you're a male versus a female with Parkinson's disease. Females have different symptoms or can present in a different way. And so oftentimes we're just starting to do a better job of recruiting females equally in equal numbers as males into research studies so that we understand both of those diseases. And how that's related to mobility is we actually find that there was a research article here that showed that females typically have more frequent falls than their male counterparts with Parkinson's disease, but males actually have freezing of gait more or have reported greater levels and more severe levels of freezing of gait than females. And so that's just to state again that, when we say general statements, it may or may not relate to you, and you need to be the sort of deciding factor for that. Okay, so our first sort of pause here, how can I preserve my mobility? I'm sure that's a question that everyone wants answered. And so my first tip, or the tip, they're not really mine. Lots of people come out with really great advice. First of all, stay physically active. And what physically active might mean for you is physical activity that you can do, that you're enjoying as frequently as you can. And also a really important part of that is being socially engaged, okay? Operate under the use it or lose it principle. You want to make sure that you're not socially retracting, not going to the grocery store, not going to your grandchild's birthday because of those factors in the environment that might challenge your balance, but instead try to get there, but make sure that you're very, very thoughtful around strategies to make sure that you're not at risk for falls, whether that be an aid if you need it, and we'll talk about that in a little bit, or just kind of going through the mental exercise of making sure that you know where the bathroom is and things that can often get us into situations where we're hurried or not really paying attention. Another great recommendation would be seek a physical therapist for personalized therapy. Physical therapy can help on a number of different ways, with balance control, with muscle strength, with gait speed, with balance, and it's been well shown to lower the risk of falls. Not everyone can find a physical therapist that has expertise with Parkinson's disease, and luckily, and we'll talk about this again, I kind of repeat a few themes throughout the talk today, but a lot of different exercises have all been really good at combating or reducing your risk of falls. There's no, one magic exercise that works the best. It all depends on your Parkinson's, on what is making your balance challenging, if it's related to your cognitive abilities or your sensory issues or your strength, etc. But having a physical therapist can help identify what is relevant for you and work on it in a tailored way. Nonetheless, exercise is an excellent way to preserve your mobility. There's aerobic exercise. I think I saw on the tables that this handout is there, so you can take a look. But there's aerobic activity, strength training, balance, agility, and multitasking and stretching. And there's some guidelines there that are specific for people with Parkinson's. And again, this has been shown to reduce the frequency at which people fall when they engage in these types of activities. And then finally, be mindful with your mental and physical state. And so what I mean by that is, Michael J. Fox has a movie out called Still. Has anybody seen it? Yeah, it's a great, great movie. One of the key moments that I noticed that he kind of works with his therapist around is actually when he gets going, his brain is still operating like he's healthy, right? He gets up and he's so vigorous and vivacious and he just goes. And that's oftentimes when he hits the ground because he hasn't really fully been aware that his feet might move a bit slower, that, he might be a little bit elevated in stress or arousal, or he might not have his plan fully formed, etc. And so what I mean by be mindful of your mental and physical state is when you get up from a chair, just take a moment, have a few breaths, decide on what you're going to do, and be really mindful about that first step and kind of getting off to the right start. Because oftentimes when we get going somewhere really quickly, especially to the washroom, that's when our feet can kind of get away from us, whether it's fascination, whether it's freezing, and we can try to avoid that by just resetting. Okay, so how can we tell if our mobility is declining? Well, oftentimes we ask you as clinicians, I'm not a clinician, I'm a researcher, but as a researcher even, when we ask, we often just ask you, how is your mobility doing? And we do that with surveys and questionnaires. Unfortunately, that's one of the primary ways, not unfortunately, it's a really important voice to have. But oftentimes, people who are filling out those questionnaires are not really in tune or might not be aware of how bad their balance might be, or the tools themselves are not very sensitive. You might get items that are just mild, moderate, and severe, and you might be going, I don't know, am I mild or moderate, or what would severe be, etc. So we really need to improve our tools, and for a number of reasons. If we want to see if you're progressing, we need to have a sensitive way to measure that. Okay, are you a 3 now, and in a month from now you're a 5? What does that mean for my therapy? What does that mean for my prescription for your activities, etc.? So we need to make sure that we're doing a good job. Clinicians often do a quick battery of assessments when you see them. You might be familiar with when they pull you backwards and you got to catch your balance, hopefully. Or when they get you to stand up from the chair and walk down the physician's office and then walk back and sit down. Those are often some of the few mobility assessments that we do when you see your neurologist relatively regularly. And unfortunately, those aren't as sensitive as we need them to be, especially given how important mobility is. That doesn't represent all of the complexities that you have in your daily life. Even just doing sort of mental arithmetic while walking can reveal a little bit more. So that's where, some of the more clinical tests that you might have taken part in with sensors and so on can give a little bit more information. But ultimately, our goal is to try to improve our measurements to make sure that we can reliably understand how bad your balance is, to make sure that we're intervening, as well as be able to detect if your balance is improving with a therapy. And so right now, unfortunately, a lot of our assessments that we have, they're pretty reliable, I would say. They're quite valid. But they could improve. One of the major limitations is the meaningfulness to people with Parkinson's lacks. So what do I mean by that? If I move your balance score, so let's say you come into the lab and I say, oh, hello, it's good to see you again. Today your balance score scored a 3. And is that 3 meaningful to you? If I move you from a 3 to a 2, did that impact your life in any way? Have you been living better, or have you been able to get out and do the things that you want to do? And so what often lacks in our measurements is that lens, which is really important when pharmaceutical companies or interventions start intervening, and there's risks always to those agents. We want to make sure that those risks are worth the reward. And so we need to make sure that our measures are reflecting meaningful change that people living with Parkinson's wants to see in their behavior. So related to this, we have a research study, and I have a few of these pointed throughout. If people are interested and live close in the region, right now internationally, we have a massive task force where we're reinventing a new measure to evaluate turning and balance and gait initiation and obstacle crossing, et cetera. Eventually, when we validate it and prove that it's reliable and it's meaningful, this might be the tool that your clinician uses to assess your balance. So long as we can demonstrate that it does what it's supposed to do and that it's a good tool. So any kind of information that you'd like about research studies, I won't spend too much time here, but you can find me after, or there's a booth outside if you're interested, and there's our contact information. Okay, so let's talk a little bit about falling. Where and why does it happen? So this first graph that you can see is they did, this is a study, a relatively recent study that was done in 2023. They followed over 1,000 people with Parkinson's. They categorized them in 2 different categories. So you can see those who've only had one fall in their lifetime versus those who are recurrent fallers. So they're falling more than once and quite frequently. It's important to distinguish these two because if you've fallen for the first time, that place in which you've had that fall could be very, very different from someone who's falling 10 times a day. So that's what the dark gray and the light gray represent. So where are people falling? Oftentimes, if they're a recurrent faller, they're falling within their home, which makes sense. They're probably not leaving their home quite as much as well. You can see that the most frequent place is in the living room, followed by the bedroom, and then the bathroom and the kitchen. And then if you're a single faller, it's much more outside of the home. So things to be aware of within your living room, are there tripping hazards? When are there cords that are sticking out? Is your home cluttered? I am guilty of sort of keeping all of the things that we acquire throughout our age. And it's worth, taking a look around and making sure that there are clear walking paths that are not going to trip you up. All of that clutter is information that you have to process as you're walking around. And so we've shown that clutter can impact your walking ability and put you at greater risk for falling. And as well as turning within sort of those tight spaces in the bathroom and bedroom between the bed and the wall, for example. Outside of the home, you have to be really careful. So outside of the home, people are typically falling on just very, very small changes in flooring. So what I said about the threshold, when you walk through your threshold in your hotel room, there's like not even an inch of a lip that goes from carpet to hard flooring. These are really, really dangerous. As I mentioned, your senses, your vision, and your ability to know where your limbs are in space are reduced. Their acuity is gone. And so you might not be able to see that lip, and thus you don't lift your toe and elevate your toe as far off the ground as you might used to have done, which goes into our building codes. And so as a result, you end up falling from those very, very small lips that can be in your home. And in terms of what is the fall-related activity, this is no surprise. Most of the time, you're falling when you're walking. Sometimes when you get up, and that can be because of static orthostatic hypotension, when your blood pressure drops as you stand and you get really dizzy. In terms of what are the perceived causes of the falls, again, you'll see with those people who are recurrent falling, oftentimes this is freezing of gait. We'll talk about that at the very end. But loss of balance is a number one cause as well. And then for people with their first time fall, the culprit is usually the trips. So those trips that I discussed with a small lip, or sometimes if there's clutter on the stairs, etc. Okay. So what are the critical risk factors for falling? The number one risk factor is freezing of gait. I got this from a brand new Richard Camisioli, who's out west. He just did a massive review of all of the literature and came out with these factors. So freezing of gait is one of the leading causes of falls in Parkinson's disease, but it's not the only one. So we'll talk about it at the very end because it's quite niche, but many, many people experience freezing of gait. The others is going to be the bradykinesia. When you walk slower, it's actually harder to control your movements. Walking slower biomechanically is more difficult. Weakness in your muscles, as we talked about, it's harder to generate if you get perturbed and off balance. And then cognitive impairment, as I touched on a little bit, but as we lose that automaticity within our movements, we rely on our attention and the frontal parts of our brain to be able to compensate for our ability to move around. And if you start to have cognitive impairments that reduce your cognition, your mental abilities, your memory, your attention, this can often put you at greater risk for falling. Okay, this is a busy slide. We've covered most of it, but again, we'll go through tips for fall prevention. So environmental adaptation, you can install grab rails, take inventory of your home. When you're inside of your home, look at the rugs. Are they secure? Are they low pile and not high pile? Definitely carpet on stairs is really challenging because it makes the stair look higher and longer than it is, and that can lead you to kind of slip and fall. Making sure that those thresholds through the door are even, and making sure that you're arranging your furniture with maximal space to remove trips and hazards and cords and clutters, etc. Working on lighting both inside of the home and outside of the home to make sure that you're not sort of in shadows or darkness. Again, trying to be proactive with the fact that vision does decline. There isn't really much strong evidence for fall prevention within the medication space. Anticholinesterase has shown to be effective in other cohorts, not necessarily Parkinson's, but when reviewing the literature, it's not sort of like there's not strong enough evidence. So I would say consult your doctor if you're looking for, if falls are a major part of your Parkinson's and you're looking for a therapy, that's probably better for a one-on-one discussion. In terms of exercise, so that's a great way to prevent falls as it is to retain your mobility. They go hand in hand. The nice thing is that across the literature, the conclusion from this systematic review was that a variety of exercise for just general fall risk is great. And you've probably heard that from Crystal, whether it's walking, Tai Chi, boxing, dance, boot camps, you name it. These are all very, very positive effects on fall prevention. Unfortunately, that's not the same story for freezing. Freezing is a little bit, as I mentioned, niche. So the general types of exercise typically can help with fall prevention, but if you're falling due to freezing of gait, unfortunately, freezing severity is typically not as responsive to those more generalized exercise therapies. Some therapies that can help freezing of gait are things like cueing, whether that's tactile or auditory with a metronome or lines on the ground. The unfortunate part about cueing, so some people, if you have freezing of gait, what you might go home and do if you haven't tried this already is if you're freezing through the doorway, you could put some lines on the door just to help guide your feet to step through that door and avoid those freezing episodes. Unfortunately, though, oftentimes cueing does wear off. So once you habituate and it becomes a habit that you start using those cues, now you're back to using that circuitry that's broken. So when it's novel, it works really, really well. But it can wear off or it might not be long lasting. There's a number of other freezing of gait prevention interventions, but like my slide around if you've met one person with Parkinson's, freezing is much the same, and we'll talk about how sort of it varies quite a bit. But therapies that have been shown to be promising are cognitive training therapies, so increasing your mental resilience, your ability to manage multiple things at once, helping to exercise that ability really helps to reduce freezing severity or reduce the number of freezes you encounter. Balance training as well as obstacle avoidance. So those Wii type of games that really challenge you to whether it's avoid the soccer balls and so on, and you're controlling your center of mass. There is a really great work in Israel done it was called the V-Time study, where they integrated a lot of virtual obstacle avoidance type stuff with cognitive mental flexibility. So they'd be calling out colors and numbers and really challenging things that ultimately reduced the number of freezing that they experienced. And then finally, assistive devices. So there's it's a balance. Assistive devices can help prevent falls, but I would say that it would be really great to, if you're going to use an assistive device, talk to your clinician or a physiotherapist and make sure that that's right for you. A lot of people can go out and kind of grab the assistive device they need from the local drug mart, but they can actually also complicate walking, right? It's one more thing that you have to coordinate, and walkers can kind of create these very narrow and confined spaces that can sometimes provoke freezing. So it's not right for everyone, and so I would really consult an expert, because what you can maybe start compensating for creates problems down the road. Okay, so I wanted to briefly touch on fall-related stress. Fear of falling. This is a major contributor to why people fall, as well as it's kind of a chicken and the egg question. It can be a preceder to who will fall, as well as freezing. Anxiety and stress play a big role in provoking freezing of gait, as well as falling. The reason for that is because as you start to worry in your mind, that's again picking up the phone on your dial-up internet. That's a thought process that has to go through that same loop that's trying so hard to focus on your movement. And so as you're having task-related thoughts, am I going to fall? Is my balance okay? What if, someone's watching me as I enter into the room? All of those thoughts are competing for processing against your walking pattern and your attentional networks that are trying to focus on it. So it can be a little bit counterproductive. And similarly, in the most severe state for freezing, we see a study that we did a long time ago. So we made people walk along a plank. And when they are way up high in virtual reality, so there's no risk to actually falling or anything, but when they're way up high, we see so much more freezing. Almost 250 episodes were captured in like 15 people. So a lot of freezing, just because we elevate the arousal system, which does a number of things in the brain, but it basically makes all of the brain start crossing its wires, and that causes interference. In terms of, if you don't know what fear of falling, so again, this study is really great because it focused on the voice of people with lived experience. So it interviewed people in terms of what is freezing, fear of falling, and how does it feel, and people characterized it, or the themes that came out was it's a feeling of vulnerability, being vulnerable to having a fall without being in control. It's daily activities and environments that are hazardous and feeling constantly fearful of those environments. And it's a loss of, and almost a grief of what once was and what could have been. And so sometimes those are the emotional components of what can go into fear of falling and the anxiety related to movement as a function of Parkinson's disease. It's important to note that this can vary with experiences as well as in different environments. So the awareness of falls and near falls, this can be fuel for that fear of falling. If you kind of have a misstep, all of a sudden you might feel your body react viscerally, and your face is flush and your heart is racing. And so this is a form of fear of falling. It can co-vary with your Parkinson symptoms. So we talked about or Dr. Fasano talked about motor fluctuations, but motor fluctuations, not knowing what state of your medication state or what fluctuations, what time of your medication state you're in, can generate a lot of anxiety around, what is my abilities going to be like in 20 minutes from now, when just prior to lunch, or when we're going to have to leave the auditorium. And so all of this is to say that the more that you have knowledge about your own thoughts and your own patterns, the more you can intervene, sort of reset. So knowledge is power, even within your own disease, to highlight where to focus sort of therapies. And we're working in this realm a little bit more. So I'll talk about, there's two studies that we're trying to understand a little bit better. So the first one is really trying to understand what is the impact of stress and anxiety on your mental and your physical capacity to control your mobility. So what we're doing in this study is we're trying to figure out why is anxiety, well, first of all, we're trying to draw the conclusion that anxiety is impacted. We hear this from people with lived experiences sharing this. We need data to confirm it. So we have people in virtual reality walk through a city. You might be walking across the street, and everybody has walked across a crosswalk. It can be a little bit stressful having to get across before the stop sign comes and the hand tells you that the traffic's going to go. So we recreate some of these and then measure all kinds of aspects of your mobility to see how it declines. Importantly, we really phenotype different kinds of people with Parkinson's in the sense that, do people with Parkinson's that have a big high level of generalized anxiety show different mobility features or resilience than people with less anxiety. The other study that we will be kicking off in the spring is piloting a new therapeutic approach. This comes out of Toronto, and we're going to be starting it in Waterloo as well, where it combines physiotherapy with cognitive behavioral therapy. So we're marrying those two approaches to try to understand, specifically for freezing, when it's the door, what is it about the door? How can we create personalized strategies to remove those autonomic or those arousal symptoms and manage them a little bit better, and then couple that with really helpful techniques, whether it's taking a big step out and then going, or whether it's sort of readying your muscles. I'm always interested to learn the different techniques within the room from people with Parkinson's that have freezing. But this will be a 6-week, it's a 12-week program, but we see each other 6 weeks, and it's one-on-one. And we'll be looking at the efficacy of this program. Okay, so finally, I'm not sure how I'm doing for time, but we'll just continue on as if we're doing great. We'll talk about freezing. I don't have my notes or anything here, but it's good. Okay, so freezing of gait. What is it and why is it important? So as I mentioned, freezing is actually the bulk of what we do at our center. I mean, we study mobility and cognition and emotion, but I'm captivated by freezing, and it actually goes back to that individual I met, 15 years ago. She had really, really terrible freezing. So it's very, very common. Over 50%, up to actually 80% of people with Parkinson's might eventually get freezing of gait. It's at most of the time it's at the very advanced stage. But as you can see here, we're learning better. So this just came out in 2020 that 30% of people with Parkinson's can actually get it in the first 5 years. Okay, 40 to 50% get it in the 5 to 10 year mark, and then 65 with estimates as number. Oh, thank you, perfect. Once it's beyond the 10-year mark. So what is freezing? If you haven't seen it, we describe it as this brief episodic absence or marked reduction in your forward progression of the feet. Basically, it's best described in the words of people living with Parkinson's. Your feet get stuck to the floor. You're trying to move, and they are glued to the floor, and so you can't, and you become stuck. But it can actually look a number of different ways. So sometimes people have knee trembling. They're trying to move, but they can't. Sometimes they can get little shuffles out, so they're walking normally, and then their walking turns to a very, very tight shuffling. And sometimes akinesia is the most severe form, where it's just total loss of movement. They're frozen in the most literal sense. And it also varies in terms of the duration. It can be as brief as a few milliseconds, or a fraction of a second, I should say, or as long as 30 minutes. People have gotten stuck in their kitchen for hours because they can't unfreeze themselves. So there's a wide variety here. And I say that again to help titrate when asking for recommendations. It really depends on where you sit within that realm. It's important to highlight that, freezing has a major impact on people's quality of life. We did work in Sydney to show that it really impacts well-being, but it also impacts caregiver well-being and quality of life. And there's a lot of caregiver burden that is recognized around freezing of gait. As you can imagine, watching your partner sort of stumble and get freezing, it's incredibly, what I can imagine, frustrating for those living it, but also very stressful. What we hear from caregivers is they're often not shouting, let's say, but cautioning their partner to slow down or to be a little bit more careful, because they're carrying the burden of the potential fall as well. So I think that that's really important to highlight. Unfortunately, it's very complex. It remains pretty poorly understood. I've got a brief video here just to highlight what freezing looks like. So freezing of gait, you can see here the gentleman is walking along, and then he kind of gets stuck right here. His foot gets stuck to the ground, and he tries to unstuck it, and eventually he gets going. So it can happen oftentimes in the off phase, so when you're in your off medication state. It very commonly happens on turns. So if you come into the lab, you might see, or even your neurologist, when looking for freezing, they should be making you turn around 360 degrees both ways. That's a very great way to test for freezing of gait. The video will continue on, but in doorways is very prominent. When you're stressed out, running or walking to get the phone or answer the door, things with a time pressure, or when doing mentally cognitive tasks. So you can see here that the person is also freezing when going through the doorway. So as I mentioned, there's many different presentations. So why is what do I mean when I say freezing is complex? It can be that trembling or the complete stuck. It's sometimes, in some people, not sometimes, in some people, it's responsive to your dopaminergic medication. In other people, it's dopa resistant, so it's unresponsive. And in a very, very small few, it can actually be dopa induced. So your medication can worsen your freezing of gait. But this is quite rare. In terms of your environmental triggers, the triggers vary for everyone. So some of our work has gone into trying to understand how these triggers might relate to what's going on in the brain, if there's multiple causes of freezing or if there's just one cause. So chores, turning, and dual tasking or being distressed can cause freezing. And then finally, the severity of freezing really, really varies. So a question that you're probably having is, are there any good treatments for freezing? What I have here is a schematic. It's not important to see it. It's a viewpoint from a neurologist, a very reputable neurologist in the Netherlands, highlighting how you can titrate or how to manage freezing. But at the end of the day, freezing is one of the most poorly managed symptoms of Parkinson's disease. And there's a number of reasons why that is. When we go to study it in the lab, we often can't provoke it. I'm sure if anybody has participated in a study, you might have experienced that. And the absence or the inability to see it in the lab makes it really hard to understand what's causing it. It's episodic, it's different in everyone, and it's very inconsistent. And so all of these things make it quite challenging to really put forward a really good evidence-based therapy. I'll rush through this, but the global or the take-home message of this slide is that freezing is incredibly complicated. And what I mean by that is, as we've gone through and taken a look over the last 20 years at what it relates to your sensory deficits within your disease, your vision, your vestibular system. People who experience freezing have worsened senses, proprioception. It's of course related to other gait disturbances, postural instability, and asymmetry. It's also related to affective disturbance. Anxiety and depression are very good predictors of who will eventually develop freezing of gait. It's related to a number of different cognitive deficits, and it's likely because those cognitive deficits are really, or cognitive abilities are really important to be able to preserve and combat freezing. And then it's also related to sleep and REM sleep behavior disorder. So again, in a similar way to posture and gait and mobility, we're working with an international consortium around the world to try to get better measurements of freezing. One of the biggest sort of stop points is that if we see you on day 1 and you freeze a lot, and we see you on day 2 and you don't freeze at all, we have a really hard time. If that's your normal variation, when we do a therapy to try to see how much you've improved, and that's how much it's varied just within the normal fluctuations, it's really hard to gather the evidence that we need to develop a new drug, which are things that we're working on, or advance new therapies. And so one of the first steps, or one of the steps in parallel that we're trying to do, is get a new assessment to really well establish whether people have freezing, what the severity is. And we work with a committee of people with lived experience as well to make sure that we're capturing things that are relevant in your life and to the activities of daily living. So if you're interested in this study, please feel free to ask me a little bit more. So finally, thank you so much. I'm sorry that I went a little bit over time, but thank you very much for having me. And if you have any questions, please don't hesitate to ask.